Rapid sequence intubation is a cornerstone of emergency airway management. It is indicated when the patient is unable to maintain own airway, if the patient can't protect own airway against aspiration, if the patient can't ventilate, oxygenate, or has a worsening course of respiratory failure. The medication usually consists of pre-treatment, which is optional, followed by induction using sedation agents, followed by paralysis using neuromuscular blocking agents. So first we're going to talk about the pre-treatment. The goal of pre-treatment is to mitigate adverse physiological consequences of intubation. The RSI causes the stimulation of sympathetic and parasympathetic nerves, causing increase in heart rate, increase in blood pressure, and intracranial pressure. It could also stimulate the upper airway reflexes, causing cough, gagging, laryngospasm, and bronchospasm. The pre-treatment should be administered at least 3 minutes prior to laryngoscopy. So it could be omitted in highly emergent cases because proper sedation and neuromuscular blockage takes priority. So we're going to use a mnemonic here to help us remember the situation where the patient could benefit from receiving the pre-treatment. It's A, B, C. A stands for asthma, B stands for brain, C stands for cardiovascular emergencies. So patient who has asthma or high airway resistance, the patient could benefit from receiving lidocaine. Lidocaine can reduce the likelihood of bronchospasm when beta-2 agonist therapy has not been given. Patients with asthma who are undergoing RSI can benefit from single dose of lidocaine 1.5 milligram per kilogram given 3 minutes before induction. The onset is 45 to 90 seconds and it lasts for 20 minutes. It is contraindicated in a lidocaine allergy and high-grade heart block. So for patients for whom a rapid rise in blood pressure is undesirable, like patients with elevated intracranial pressure or significant cardiovascular diseases, the fentanyl could decrease the cardiovascular effect of sympathetic nervous system stimulation. So for a patient who has stroke, intracranial hemorrhage, meningitis, encephalitis, traumatic brain injury, hypertensive encephalopathy, acute coronary syndrome, aortic dissection, angina pectoris, recent MI. Those patients could benefit from receiving fentanyl as a pre-treatment agent. Fentanyl is an opioid receptor agonist, and its effects begins with 2 to 3 minutes of administration, and the duration of action is 30 to 60 minutes. Fentanyl can cause respiratory depression and hypotension. So in patients with tenuous hemodynamic status, fentanyl should be avoided or given at a lower dose, like 1 mics per kilogram. So I have written here that it's contraindicated in hemodynamic instability and shock. Then after the pretreatment, for patients who need the pretreatment, or we could, some patients could just go on for induction agents, which provides amnesia, blunt sympathetic response, and can improve intubating conditions. When a paralytic agent is used for intubation without sedation, the patient may be fully aware of his or her environment, including pain, but unable to respond. In addition to inhumanity, this circumstance allows for potentially adverse physiological response to airway manipulation, including tachycardia, hypertension, and elevated intracranial pressure. Sedative use prevents or minimizes these effects. Also, clinicians can select an induction agent that both facilitates RSI and ameliorates the patient's underlying condition. So in this chart, I've summarized 4 different induction agents that are commonly used for RSI. They are etomidate, midazolam, propofol, and ketamine. Etomidate and midazolam and propofol, they share the same mechanism of action. They are all GABA agonists. So upon activating GABA receptor, there is an influx of chloride, which inhibits the neuron by creating hyperpolarization states. This causes amnesia and sedation. In addition to amnesia and sedation effect, midazolam has anticonvulsant effect. And propofol, also in addition to amnesia and sedation, it has a bronchodilation effect. Ketamine, on the other hand, works on different receptors. It is an NMDA antagonist, so it creates amnesia and sedation. It excites opioid receptors, and it is the only agent that has an analgesia effect among the induction agents. It also stimulates catecholamine receptors, which results in increase in heart rate, contractility, MAP, and cerebral blood flow, and bronchodilation. It also decreases vascular nitric oxide production, which leads to vasodilation. The onset for all of the induction agents in the chart is less than a minute, and the duration of action varies. The dose for etomidate is 0.3 milligram per kilogram. Midazolam is usually 0.2 milligram per kilogram. Propofol dose ranges from 1.5 to 3 milligram per kilogram. And ketamine dose is 1 to 2 milligram per kilogram. So etomidate is usually the drug of choice for hemodynamic stability. However, it does come with some concerns because it could lead to adrenocortical suppression. So it's used cautiously in septic patients. The adrenocortical suppression could last 12 to 24 hours, and it results in low blood pressure. And since it's critically important to maintain adequate blood pressure early in treatment of sepsis, some clinicians might not use for this reason, or some might use with a single dose of glucocorticoid like hydrocortisone 100 milligram IV if they manifest hypotension that is refractory to treatment with aggressive fluid resuscitation and vasopressor. Etomidate also causes myoclonus, which is like a brief and minimal muscle jerk. So usually it's used with caution in septic patients and avoided in actively seizing patients. Midazolam, since it has anticonvulsant effect, it is a good agent for status epilepticus. And propofol, since it has bronchodilation effect, it could be beneficial when the patient has bronchospasm. But midazolam and propofol, both of them has a dose-related myocardial depression, so it should be used with caution or generally avoided for hypotension, hypovolemic, and shock. Also, propofol has soy and egg in it, so it should be avoided in soy and egg allergy. Ketamine, since it stimulates catecholamine receptors, it increases heart rate, contractility, and it also has a bronchodilation effect. So it could be excellent for hypotension or a patient with bronchospasm. But there is a new study that patients with decreased catecholamine due to underlying disease may develop hypotension. So it should be used with caution. Also, it's controversial for increased intracranial pressure and increased blood pressure. Last but not least, we have a paralysis agent that should be given immediately after induction agent. We use neuromuscular blocking agents, and they differ by their mechanism of action. So we have depolarizing NMDA and non-depolarizing NMDA. Under depolarizing neuromuscular blocking agents, we have succinylcholine that binds to postsynaptic acetylcholine receptors of the motor end plate that causes transient fasciculation, which leads to muscular paralysis. The onset of succinylcholine is rapid, 45 seconds, and the duration of action is short. The dose is 1.5 milligram per kilogram IV based on actual body weight, even for morbidly obese or pregnant patients. But it is contraindicated for patients with a personal or family history of a malignant hyperthermia. So we don't have a full history usually when the patient requires RSI, and sometimes it's given without knowing that the patient has a family history of malignant hyperthermia. So if in that case, we could treat by giving dantrolene 1 to 2 milligram per kilogram IV. Also, if the patient has suspected hyperkalemia, it should be avoided, such as patient with profound tissue damage, burn, crush injuries, rhabdomyolysis, inherited myopathies, and hemodialysis, and long course. So we have several non-depolarizing neuromuscular blocking agents, but most widely used and recommended non-depolarizing NMDAs is rocuronium, which works by competitively inhibiting postsynaptic acetylcholine receptors of the motor end plate, which prevents depolarization and inhibits all muscular function. The onset is slower, 60 seconds, and duration of action is longer. So it requires post-intubation sedation due to long duration. The dose is usually 1 milligram per kilogram IV based on ideal body weight. And since it does not cause membrane depolarization, the side effects seen with succinylcholine do not occur. Rocuronium also has an antidote called Sugammadex. So succinylcholine remains a drug of choice for RSI, but rocuronium may be substituted in cases where a contraindication to succinylcholine exists.